What are the most common three types of cancer?
The commonest one is tobacco-related cancer. In the females, 35% cancers are breast cancers. Most of people, I think, once they have the doubt of the diagnosis of cancer, they think that is a death sentence. Once we say it's a cancer means, they'll think that I'm going to die tomorrow. Fear of cancer. So all these factors make them to stay away from the hospitals. But at the first time, if a doctor gives good counseling, I think most of the cases, I think that if we detect early, we'll cure the cancer.
Dr. Sada Sivudu Gundeti, thank you for joining the Impact Show podcast. We are very honored. Thank you for giving us the time.
Thank you very much for the invitation, and definitely we are happy to share our experiences in this Impact Show. Thank you.
I would like to ask you, what are the most common three types of cancer in India?
Yeah, the commonest one, cancers in India, is again, we broadly divide them into male cancers, female cancers. Coming to the male, the commonest one is head and neck cancer. That means that the head and neck means tongue, lip, buccal mucosa, and pharyngeal cancers. We'll call them as head and neck cancer, the commonest one. The second one is lung cancer, and third one is gastrointestinal cancers. So coming to the females, the commonest one is again the breast cancer in India now. The second one is carcinoma cervix. The third one is, I think we can say this, carcinoma endometrium or ovary. So these are three cancers in females. But combining both the sexes, both the genders, so the commonest one is again head and neck one is the commonest one, and second one is lung cancer is the second most one now. So maybe third one again it comes to again other cancers like breast cancer, it will come into the picture. So at this point of time, the commonest one is, we can say simply, female breast,
And then,
and head and neck is the male cancer
sure,
one. Yes.
sure. Would you say head and neck takes about 35%?
Yes, actually, it's more than one third. Actually, cancers now are diagnosing in our center or all over India is more than one third of the cancers now. Head and neck in total. That means usually some people, they'll divide them into tongue cancers are different, buccal mucosa cancer is different, pharynx are different. But combining all these sites, more than one third of the cancers are head and neck cancers. All these cancers are tobacco related one. Very rarely some people, they may not have the tobacco chewing habit. We can say something, this sharp teeth, some dentures, it leads to chronic irritation. That leads to the cancer formation. But the percentage is very, very minimal. The commonest one is tobacco-related cancer. So in the males, I think it's more than one third. In the females, more than one third. Actually, you can say around 33-35% cancers are breast cancers now. Yes.
Okay. And what is the pathway usually when you diagnose a patient with a cancer? What are the waiting times for treatment or post-treatment? So what is the pathway?
I think that's the good question you have asked now. Most of people, I think, once they have the doubt of the diagnosis of cancer, they have so many fears in their mind. So cancer diagnosis is, they'll think that is a death sentence. It's not a death sentence at all nowadays. First thing is, the primary care physician should give the proper guidance to them, go to a good center where they can get the proper diagnosis, proper staging, and proper treatment. In India, I think if any patient comes from remote village or remote town, they can reach any cancer center within one day. Immediately, once they reach the cancer hospital, we'll see the symptoms, we'll see their primary investigations. Based on that, we'll do some basic confirmatory test. Initially, they have the only doubt of the diagnosis. But once we see the patient, so we have to confirm that most of them, they have the doubt whether they really do have cancer or not. So we'll do some basic investigations like biopsy. So we'll do the biopsy. Once we get within 1 or 2 days, there is no waiting period in India. They can go to any center. All these tests are done within 1 to 3 days. The first thing is, we'll do some investigations to confirm the diagnosis. That is a biopsy. The second one is, we do some investigations to know the exact stage of the disease. Whether first stage, second stage, third stage. So that is a simple, again, imaging, we'll say that one. Imaging, we have the CT scan, we'll get the appointment within 1 day.
Sure.
Only thing is PET scan we'll do. PET scan means, I think FDG PET we have nowadays is a whole body PET scan. That can be done in a nominal price in India now.
Okay.
Within 10,000, they can get the whole body PET CT.
Okay.
And that they have to be in the fasting, so that can be done next day. So ultimately, all these investigations to confirm our stage of the disease. Okay. Once we know this diagnosis, stage of the disease, the next one is plan of treatment, what to do next. So then again, we'll have most of the centers, we have the tumor board. So tumor board consists of medical oncologist, radiation oncologist, surgical oncologist, radiologist, pathologist, nuclear medicine physicist, all the specialties, they'll sit together. They'll discuss about this case, what we can do next.
About, of course, like MDT.
Yeah, correct.
Okay.
Multi-disciplinary tumor board, we can say. So once we have that type of tumor board discussions, we can do the justice to the patient. Whether the patient will go to the surgery first, or chemotherapy first, or radiation first. So because all the departments will involve in decision making, even sometimes we'll invite the patient also. Really, if the patient is willing to discuss, but of course most of the patients, they're not willing to come to these boards. But we'll share the information what we have discussed in the tumor, my MDT.
Sure.
And we'll inform them. So what is this is our opinion. Do they have any challenges to take the next step in the form of treatment, either surgery or radiation? And we'll, at the time of counseling, we'll take opinions of the not only individual patients, we'll talk to the whole family members. Here Indian context is the family support is most important. So because they may not prepare to stay in the hospital for 1 week or 10 days for the treatment sake. So we will give them sufficient time to take a proper decision. And another thing in Indian context is financial issues also may be there. So I think whether they are prepared mentally for the financial issues or not. So the counseling takes minimum half an hour to 1 hour. So we'll sit together, especially the primary care physician, the medical oncologist or surgeon or radiation oncologist, they sit together with the patient and their family. We'll discuss the plan. So this is our plan. So do you have any concern or any limitations? Most of the people, they'll say, we'll go and come back because 1 or 2 days they have to prepare their family at home and they have to come back to the hospital. The second thing is again the financial issues. Luckily in India now we have the state-sponsored insurance. In Telangana, Andhra, we'll call it as a Arogyashri. In our central government, they have something like an Ayushman Bharat. So under these policies, the patients will get the minimum basic treatment at free of cost. So with that, I think we are able to provide the basic care of each and every cancer patient, and we'll counsel them. If they need any extra money or extra cost, again we'll give them some Chief Minister Relief Fund one letter. The letter will go to the something like the Chief Minister's office. If it's really justifiable, they'll also give the extra amount other than this package amount of state insurance policies. So in our center, we do even bone marrow transplants, and we do surgeries, and we do kidney transplant, heart transplant, lung transplant at free of cost in our center. So the government has so much of willingness to participate, spend money on this issue. So they have taken it as something challenging program. Successfully for the last 4-5 years, we have been doing this, all the transplant under this Arogyashri program in Telangana and Andhra.
I'm not denying about financial challenges for the patients, but what about emotional challenge? Do you have any barriers to convince their family?
You asked the right question. Really, that's the emotional part is most important actually. I said, once we say it's a cancer means simple, they'll think that I'm going to die tomorrow. So that I think the emotional part, especially that fear of cancer, myths about the cancer. So all these factors make them to stay away from the hospitals. But at the first time, if a doctor gives good counseling about the disease, if you give something positive note and true value of the treatment, and they can live longer. I think most of the cases, I think if we detect early, we'll cure the cancer. But if we diagnose late stages, for example, lymphoma, whatever may be the stage, it is curable. But breast cancer, lung cancer, whatever may be, especially the stage 4, once upon a time we say 6 months survival. Now we are saying 3 to 4 years they can lead normal life without even jeopardizing their regular employment, family life. So with that, I think we can counsel them that in early cancers, we'll cure it. Locally advanced also, we'll give some form of therapy. Still, there is a possibility of cure. Even advanced cancers also, we can give the good quality of life and good quantity of life also. So if you give that assurance, that most of them, they'll emotionally, they'll feel comfortable. Okay, I am not going to die tomorrow. So meanwhile, I can take care of my family, my something wishes. Some people, they wanted to go to some, what you can say, spaces for especially Muslims, they wanted to go to Makkah, and Christians, they wanted to go to their places, and Hindus, they wanted to go to their, so many people, they had so many spiritual ideas actually. Once they get any health problem, they wanted to go to some their spiritual worship places, they wanted to pray and they wanted to come back. So the emotional part, spiritual part, and at the same time physical part. Some people, they will say chemotherapy will make us so sick by losing their hair, hyperpigmentation or some black color and white color, and they'll have so many notions about the chemotherapy. Now we have the good therapies like targeted therapy. Simply they can take the tablet. I think nowadays, for example, I'll tell you the best example is chronic myeloid leukemia, one blood cancer. Once upon a time, the people, they said it's a blood cancer means death sentence. But in 2002, there is one drug, a miracle, there's a magic bullet, they said initially. It's a Gleevec, one imatinib tablet. If they give the tablet, it hits the only cancer cells without damaging the normal cells.
Okay.
So the people in just like a diabetes, hypertension, simply they can take one tablet, they can ignore this. Now, in our center, we have more than 3,000 to 4,000 patients on just with this capsule. Now, more than 22 years, they are living longer without any major side effects, in the sense they are kids now, they are doing their education, they are going for jobs, they are getting married, they are going to have their children also. So marriage, having children, and leading this normal life. So science is developing day by day. So if we counsel them, most of the patients, once they listen to the successful stories, I think they will be emotionally, once they will be stabilized. Once I think emotionally stabilized, we can give the whatever treatment, I think that will work in a better way. So it takes, I think, like in a holistic way. So not just, we should not take a cancer as a disease itself. We should take it as something, a whole perspective, and treat that individually holistically. So physically, mentally, psychologically, emotionally, and spiritually. So once you touch each topic, and I think you can always, we have to talk in terms of their doubts, their concerns. I don't want to talk continuously about about my feelings, but what are their feelings actually, what are their concerns. So some people, they wanted to know about disease, life, job. Some people after treatment also, some people, they wanted to go for job. The cancer, I think some people think once the cancer diagnosed me, they have to sit at home without doing any job. They'll think in that way. No, it's not like that. They can have their normal life. So if you give all the assurances and answer their queries and questions and concerns, and we can make it a good environment. So where I think whatever you give treatment, like in good soil, the simple seed that will grow like a good sapling, then it would become a good tree. So I think that's the way I think we should treat the patient, and especially oncology cancer patient means you have to touch each point delicately, and with more of passion and compassion.
You mentioned about the capsule. What is it called?
Imatinib, tablet. There's a tablet. There's a thyroid.
Is it expensive?
It's not. Once upon a time it was expensive, but now with generic version has come 1,000 rupees per month. So, but even though at the time of the costly 1.2 lakhs per month at that point of time, 2002. But some foundation, the Max Foundation, and Novartis people with their corporate social responsibility, with the compassion, they used to give the medicine free of cost.
Okay. Is
So-
is there any particular way they have to take? Is it weekly or monthly?
Daily tablets. It is a
Okay.
daily tablets.
Okay.
Until they have diabetes and hypertension, they can
Sure.
take it daily.
Okay.
So I think that showed the oncology a path-breaking way.
Hmm.
So since then,
Hmm.
so now whenever we get a cancer or patient and simply we take the tissue,
Hmm.
we'll subject the tissue for genetic analysis. That's not a molecular analysis.
Hmm.
So once you know the molecular analysis, where is the abnormality?
Hmm.
So once we know the abnormality, the researchers are trying to develop some drug, some target, just they're hitting the target without affecting the normal tissue, because most of the side effects of therapy because of this chemotherapy only, because it will affect the normal tissue. But these all the target therapies are just to hit the abnormal cells, that is cancer cells.
Okay.
So now we have so many, at least hundreds of tablet forms are there available now.
Hmm.
We are able to give the same type of drug that is known as tyrosine kinase enzyme inhibitor, TKIs.
Hmm. Hmm.
So we have the TKIs in kidney cancer, TKIs in liver cancer, TKIs in breast cancer.
Okay.
So you can name it, because we are able to understand exactly why the patient is getting this disease
Hmm.
and why. So each individual is different now. Everything is personalized.
Hmm.
Even breast cancer, we have so many different types of breast cancers are there.
Hmm.
Lung cancer, different lung cancers are there. Like example, some EGFR, some mutation positive, some ALK positive, some RAS positive. So not as lung cancer means, don't think that is one single disease. In so many
different types.
subtypes are there. Each subtype we have separate different drugs are there. And with the drugs, they are even stage 4 cancer patients. They are living for a minimum 3 years now.
Okay. Okay.
Once I did my DM in 2005. At that time, I used to counsel the patient only 6 months you will live. But now I can confidently, you can live minimum 3 years. Maximum, I think that's all.
Oh, sure.
So
Sure.
with that confidence, with the development of science, molecular analysis, and industry also, they are trying to do more research, trying to find out the abnormal pathways, trying to hit those things, and we are able to, they are living longer without any major side effects. That's important.
Sure.
Only one thing is, I think, as I say, something financial issue is the only one. But once a generic comes into the picture, the cost, once upon a time, this 1.2 lakhs drugs in 2002, now we are able to get for 1,000 rupees. You can imagine. I think this definitely the cost will go down gradually.
Sure.
Yeah.
Sure. We discussed so far about diagnosis, treatment, and the challenges for you to prepare the patient. What about post-treatment? Do we have anything palliative, like Macmillan in UK? Do we have any charities who look after the patients emotionally, financially?
Frankly speaking, like this Macmillan is a big one. I think in India.
No,
we don't
sorry, I
have-
just gave for reference.
Yeah, but it really that type of things we don't have much. But we have some patient support groups. Like for example, multiple myeloma. Some specific groups are there.
Okay.
Chronic myeloid leukemia. The Max Fund, the Friends of Max. So they will support that group of the patients.
Sure.
And ultimately, these are all the groups they will form and they support each other, especially emotional support. Sometimes they can go for even financial support also. If they take the membership of one for paying 500 rupees, they'll pay that
Discuss.
amount for the test actually. For example, some tests are very costly, 3,500 rupees for 3-4 months. So they'll sponsor that one. So membership. And these are the things for basic disease specific are there. But some charities are there. They'll take care of especially palliative setup, what you asked, the palliative care. The palliative care in Indian context is most of people, they think that is end of life care. But palliative care doesn't mean that exactly. But I think some people, they have the notion of end of life care. End of life care, we have the now good charities in Hyderabad, especially some Sparsh Hospice in Kajagoda. Even MNJ Cancer, Regional Cancer Center, we have the palliative care department. And one more center is Kukatpalli, also Ramdev Hospital.
Okay.
They have the separate palliative care centers.
Sure.
These are all voluntary services, non-governmental agencies. They will do the service at free of cost. And they are doing a great job, especially as you said, they'll touch upon each and every part. Most of the pain, emotional and psychological issues, sometimes even spiritual issues also, they'll take care of that one. If the patient is very sick, He may not be come to the hospital.
Mm.
So then these people, they'll go to their home, and weekly one visit also may be there.
Mm.
And they'll counsel them, they'll address their needs of the individual patients now.
Yes.
So some are there, but they may not support the financially, but they can support physically, emotionally,
Mm.
and treatment or supportive care at free of cost.
Mm.
Yeah.
I want to ask you about the role of stem cell in treating a cancer patient. At NIMS, what do you guys do? Can you explain the process?
Yes, sir. Actually, the stem cell transplant is a very good technology now.
Mm.
So basically, stem cells means some people, they'll think that nowadays everybody they are using some stem cell can be used anywhere that will transform to different types of cells. It is not possible at this point of time. Especially this approved technology, proved science in bone marrow transplantation. That's known as stem cell transplantation. Usually, this we broadly will divide them into 2 or 3 categories. Autologous stem cells. Autologous means we'll collect the stem cells of the same individual, keep it aside, and we'll give the chemotherapy that will kill the cancerous cells. And during that time, I think they may damage the normal tissue also. Just again, the same cells will reinfuse to the same patient. So they'll engraft after some time. It is known as autologous transplantation. This transplantation we usually will use in multiple myeloma and some many refractory and relapsed lymphomas. There are specific indications are there for this one. And coming to the blood cancers, because all the stem cells are diseased ones or genetically modified ones. So what we do, just we'll collect their sibling stem cells. Usually sibling means as a brother or sister, or sometimes haploidentical, either mother, father also we can collect the same stem cells. If these two are not possible, sometimes we'll go for something like matched unrelated donors. There is a one Datri in India. Just we'll submit our HLA typing to them. They'll search in their website and they have their own list. So they'll try to find out the matched donor. That is known as matched unrelated donor. Not related to our family. So it's not a mud. So again, those stem cells, what we'll use in refractory leukemias. For example, blood cancer is a genetic disorder, sometimes chromosomal abnormality. We can't use the same person's stem cells. We have to use a different person's stem cells. So we'll collect the stem cells, preserve, and we'll give the high dose chemotherapy. So these stem cells will go and stay in the bone marrow. That is known as engraftment after 1 to 10 days. Then again they'll start growing and they'll start producing the WBC, hemoglobin, RBC and platelets. It takes some time. During that time they may get infections. So for that sake, I think we have to create a very specific environment. That environment is the HEPA filters, we'll say that one. Each room contains something good HEPA filters which will filter the virus, dust and bacteria. So in NIMS also we have around 8 suites are there. At a given point of time we can do 8 transplants. At a given point of time. At this point of time we have 7 patients in our ward now. So all are just we are doing autologous, allogenic also we are doing, and all these transplants also again the principle is just trying to cure the cancer. So not for just only to give some palliation. So luckily the state government of Telangana and Andhra, we have these facilities under Arogyashri program. So
even for stem cells?
Yes. We can treat all these patients at free of cost. So the great thing about Telangana, Andhra, at least our politicians or policymakers, they're very intuitive. They wanted to listen whatever we say because the good centers are there. Our intention is very good, so they are supporting us in that way. We are doing many transplants, and once upon a time, hardly we do 10 to 20 per annum. Now, just we are doing 50 to 60 per annum now. Maybe that number may
just
increase.
At NIMS?
At NIMS itself. That number may increase. I said no, 8 rooms per at a given point of time. And 8 usually can is up to 100 we can do in per annum now. So at free of cost, I think all the central government employees, poor people, they can get this treatment at free of cost in NIMS. We have that facility. And the principle is again, the patient has to be there for 1 month. But there's only one thing, I think the whole family should prepare that. They have to stay in that room for at least 2 to 3 weeks to avoid all the infections and something.
Because you said HEPA filters.
Yeah, that's the thing. So only thing is, I think again, as you said, we have to counsel the patient for all angles because the family, kids, maybe they're at home. They have to prepare everything now. So I think, but the treatment whatever we are giving in our center or in Hyderabad,
Mm.
same treatment you can get in UK and Europe.
Okay.
Same treatment you will get in you can say America also.
Yes.
But maybe the different scenarios. But all the diagnostic modalities, especially this imaging, I said something PET scan
PET,
and all
yes.
the PET scans
Mm.
and molecular test,
Mm.
especially NGS, next generation sequencing.
Mm.
The people they'll say they'll sequence the whole gene
Mm.
and they'll find out where is abnormality.
Wow.
That test also available in India now,
Mm.
and we're able to find out. And we are able to get the drugs also. For example, any drug which is approved by the FDA
Mm.
or EMA in
Mm.
Europe, and within I think 1 or 2 months we are able to get the drug. At least we can import it initially,
Correct.
but later
Later
our
on.
government and will give the permission for DCGI, that will give the permission. Then we can
Develop.
they can market the drug in India. So I think almost I think we are on par with any other developed country.
Excellent.
We are able to get the all modalities from diagnosis, treatment, and post treatment.
Yes.
For the follow up also, what you
Mm.
said is only thing is because some especially in Indian context, some people they'll say once the treatment is over, they think that everything is over.
Mm.
But no, it's not
Mm.
right actually. They have to come to hospital every 3 months, first 2 years.
Yes.
There is only one I think lacune we have in our center.
Mm.
We don't have a strict follow up to take care of this patient. We every third month we have to call the patient. Because we don't have that system to remind them come.
Mm. Correct.
Only thing is the patient they has to take their own interest and they have to come regularly. So, but we'll counsel them usually. 90% of people they'll come regularly
Sure.
to the because again the post treatment follow up is most important, especially any side effects
Mm.
because of our therapy,
Mm.
or there is a possibility of recurrence and relapse in the future also.
Mm.
So if you detect that relapse at early stage, again we can cure the problem.
I want to ask you about a very basic question. How can we detect early about cancer? Is there any symptoms we need to look out for, or how do we detect cancer?
Yeah, there's a most important question you have raised now. This early detection is the most important one. Once we detect the cancer at early stage, we can cure the cancer.
Mm.
So more than 70 to 80% of the cancers are curable. The condition is if you detect at early stage.
Yes.
So I think we have some modalities of the early cancer detection.
Mm.
Those are known as screening modalities. So in breast cancer, we have this mammogram. Okay, so once we prescribe these mammograms after 45 years, at least yearly once they can go for something mammogram checkup.
Mm.
But females also, we again will ask them to go for this pap smear examination and HPV testing. Cervical cancers, simple, very small test. It doesn't even cause any pain and financially also very, very viable. Most of the government centers, they do it free of cost.
Mm.
But if you do something pap smear and HPV testing, if both are normal, I think for consecutive 2 to 3 years, I think they may not get the cancer next 5 years. So ultimately, we have certain modalities of screening for certain cancers, not all cancers.
Okay, sure.
Breast cancer, mammogram, cervical cancer, pap smear, and HPV testing. And another common cancer is head and neck, what you have mentioned. It doesn't require any special test. Only they have to go to dentist or surgeon or ENT doctor. So then simply they'll throw the light and they can see any patch, white patch, any red patch, any non-healing also. That means there's all the pre-malignant conditions where we can detect at early stage. So there are 3 common cancers in India. At this point of time, all the guidelines are very well established, are written, and government also circulating all the guidelines to all the hospitals. Now in the future, this government is insisting on all the medical colleges should have these facilities to detect at early stage. So most of the centers, they should have these basic facilities to detect at early stage. And once they find any abnormal report, they have to refer these patients to the higher centers, like tertiary cancer centers, where they will get the full evaluation. At the same time, they can start the treatment if it is cancer. If it is not cancer, everybody will be happy. But any suspected case at periphery, that should be go to the cancer center, where they will do some special investigations, like in a biopsy. They can confirm the diagnosis. This is the second one. And in certain countries, especially US and UK and India also, we can go for colonoscopy for colon cancer. After 50 years, better to have once one colonoscopy. But very rarely they will do something like a stool for occult blood. Small quantities of blood can be detected. So, but that is not regularly practiced in India.
Sure.
And another one is now the people, they are thinking that the commonest cancer again in India is the lung cancer, what we have to say. So lung cancer, if any patient is, not a patient, any individual, if he smokes for more than 15 years, 20 packs, what you can say 20 cigarettes per day, so we'll calculate them something like 30 pack years. We'll calculate something like based on the cigarette number and years of duration of smoking. If they have something with 15 years of history, they have to undergo low dose CT scan. Some CT scan, which will not cause any major radiation exposure, radiation side effects. So it's known as low dose CT scan. We can detect at early stage. If you have any doubt in that, again we can go for PET CT. Even if you have something very small noodle, you can remove that one and simply we can cure the problem. So ultimately, we have to create the awareness among the first practitioners of the periphery, because they should be aware of all these things, what the screening modalities. Then the media, especially digital media nowadays, they have to just project on these all the modalities are available, affordable, and accessible to each and every individual. So once we can say all these things, I think most of people nowadays, they're very cautious about their, after COVID, I think most of the people, they're concentrating on their health now. I think once we say that one, definitely they can go to any center, they can get all the tests done. I think within 1 or 2 days, they'll get the report. So early detection is important. We have all the screening modalities and guidelines. How frequently they have to go for the testing also important. That can be done. So only thing is what you ask, one more is again, if any family history of breast cancer, for example. So there is a possibility of 5 to 10% the other members may get the cancer. That is known as hereditary cancers, hereditary breast and ovarian cancers. So those individuals, for example, a mother has the breast cancer at the age of 50. So we'll ask them to go for this testing at the time 40 years, 10 years earlier to that one. Actual recommendation is 45, you can say that one. But if the mother gets the cancer at 50, she has to undergo the same procedure, starts at the age of 40, 10 years before the first diagnosis. Only certain areas, I think, we'll modify these guidelines. Ultimately, we'll give the proper guidelines because any family member has some cancer, especially breast and ovary and stomach. There's a possibility of genetic risk. It may not be the 100%, they may not get the disease. We have some genetic testing also available in India, in abroad also. Simply BRCA BRCA testing, BRCA1, BRCA2. So once you do that one, I think if it's their same gene is sharing by the individual family members, we'll ask them to go for regular screening modalities. Once they go to regular screening, we can detect the cancer at early stage, we can cure the problem, and we can motivate them for this one. So any family has 2 or 3 members suffering with the similar cancer should be a little bit careful. Talk to their doctor, go for some genetic testing, and take the precautions. Once it comes positive, don't think that I am going to get the cancer 100%. Because, for example, if you take the Angelina Jolie, so BRCA1 positive, I think that she has undergone some bilateral mastectomy, and they have so many modalities are available now. These are known as surgical resections or surgical cancer preventions. You can say one is the medical prevention, surgical prevention. There are so many modalities are available based on their requirement. Only thing is they should not have any fear of cancer and go for some testing. Follow the guidelines. That's all.
I want to ask you a question very blindly. I'm not sure how many audience will like it. I want to touch upon sedentary lifestyle. What is the percentage from your experience we have seen? I'm not saying just because of sedentary lifestyle they are getting cancer, but it is part of it.
I think the cancer development is a multifactorial. So because a person is sitting at home, he will not get the cancer directly. So there are multifactors. Some people are smoker, alcoholic, sedentary lifestyle, genetic problem. So many factors will play it. So, but these are the preventable things. we'll divide these risk factors into modifiable risk factors, non-modifiable
Right.
risk factors. Non-modifiable age, we can't modify it. Genetic background, we can't modify it. At least some risk factors we can modify, especially obesity and sedentary lifestyle. Just 5 days a week, 20 to 30 minutes walk is more than sufficient, actually, you can say simply. That one. If they have something good, something about this yoga and meditation, definitely they play major role psychologically. They'll feel very happy. So they'll keep you away from all the diabetes, hypertension, and of all these chronic disorders also. So meditation, yoga definitely play a major role in prevention. And those things also, they make a person physically, mentally fit to take the challenge. So they'll accept the problem. So a spiritual human being, always they'll accept the problem, like instead of why I should get this problem. Instead of okay, I got this problem, God has given to me.
How I have to deal with it.
I have to deal it with. How to deal, that is a different issue. But He has given me the problem, He will also give the solution also. If the people who are practicing more meditation, yoga, they'll have that positive attitude towards the problem. Instead of saying, why me? Okay, I got it. Now I have to do next. What to do next? So again, now these things, I think sedentary lifestyle, especially diet, I think we should concentrate nowadays. I think diet, I think most of us, we don't eat properly, timely. And because of schedules of all the night schedules, daytimes, we neglect our diet and the lifestyle, especially sleeping patterns. Because of digital world, everybody will spend more time on this again. Mobile by sitting, and this stuff I think they can, whenever they get a call, they can go and talk continuously instead of sitting at home. And in that way they can modify the lifestyle a little bit. Definitely we can avoid this sedentary lifestyle, but sedentary lifestyle will not cause cancer. Just don't think in that way. But it's multifactorial, but it adds something to that, all the some fuel to the fire.
Yes, thank you. Last but not least, I want to ask you about, would you give any tips or message to the upcoming oncologists who want to service in this field?
Yeah, that's also again most important. Once upon a time, after completion of my MD, I wanted to become a medical oncologist as a cancer specialist. One of my teachers says, what do you want to do in cancer patients, right? Because of the 25 years ago, the cancer diagnosis means the only death sentence. But now, we have so many advances in terms of prevention, early detection, early diagnosis, and early treatment. And treatment also, we have so many modalities like radiation therapy. We have special techniques. They can improve the life without damaging normal tissue, and they can cure the cancer. We have the surgical techniques also. Initially, we used to open the abdomen, laparotomies. Now laparoscopy. Now robotic surgeries have come to the picture without even opening this. So many advances. Just prostate cancer, simply they'll do the robotic surgery without even having the big scar. So we can cure the problem. And third thing, coming to the medical oncology, like chemotherapy. Once upon a time, people used to think of losing of hair, hyperpigmentation, fever, nausea, vomiting. Now, nothing. Just we can able to deliver the best chemotherapy, best target therapy, and immunotherapy also come into the picture now. So many modalities are available based on the individual needs now, not as something as a whole. So personalized therapies are available from radiation, chemotherapy, immunotherapy, target therapy, and surgical techniques also. So many advances are there. If we have the passion towards the cancer, definitely we can make a big difference. Any individual which has something interest in oncology, so little bit they should have some spirituality, compassion, and holistic way of approach. How we can help this patient, not only physically as a diseased individuals, mentally, spiritually, even sometimes financial support also. We may not give from our own pocket, but there are so many NGOs, they're supporting them. Tap that one. And people are willing to nowadays, most of the industries, they have some corporate social responsibility. They have to spend at least 1% of their income to these common causes. So we have to tap that one. And ultimately, all of them, they're very much interested. If it goes to the right cause, they're willing to do that one. So financially also we can help. So, but take an individual as a holistic way
Approach.
and holistic approach, help them in all angles. We can do that. So with that, I think I can say that one confidently, a cancer is not a death sentence at all.
Thank you. Thank you.
Thank you.
Thank you.